SBU is the Spina Bifida Association's new viral education program. Our goal is to bring the world's best care providers and resources directly into your home. SBU is the only free webinar series dedicated solely to the educational, employment, social, self-advocacy, and health needs of people with spina bifida. We hope that you will enjoy today's presentation: medical management and procedures, neurogenic bladder, late childhood to adulthood, and that you take the time to complete the evaluation at the close of this presentation. This session was made possible by an unrestricted educational grant from Hollister.
Everyone, thank you for coming. This is a little bit different this year. We're going to have two speakers talk. We have different backgrounds and similar interests. I'm Rosalia Messeri. I'm a pediatric urologist at Riley in Indianapolis. I care for primarily children, but I also care for young adults with spina bifida and some other congenital urologic conditions. So about 85% of the time I'm taking care of children, and about 15% of the time I'm taking care of adults, and primarily adults with spina bifida. So that's one of my true interests and passions in urology. And Dr. Wood is one of my colleagues from Cleveland, and I'll have her introduce herself and give you a little insight into what she does.
Thanks for coming. I'm from the Cleveland Clinic, and my area of specialty is in adult reconstruction, but certainly I think Dr. Messeri and I share a similar interest in this area of transitional care and care of patients in particular with congenital anomalies as they come into adolescence and adulthood. So it's always interesting to spend time here talking with patients, but also talking to my colleagues, because everybody brings to the table a little different perspective on how to address the challenges of this population, not just of spina bifida patients, but patients with all sorts of congenital anomalies. So I'll just sort of segue into the overview of our talk. We will be first sort of talking about transitional urology, which I know that many of you have heard about, transitional medicine yesterday with Tom's talk, as well as some of the other talks here. But I think in urology, this is a particularly important area that's developing, because urology, adult urology or general urology focuses on really completely different issues than pediatric urology, in particular with areas of sexual function, as well as time goes on, if people live long enough, they're bound to encounter some sort of urological problem. For the men in this audience, the prostate is an organ that inevitably gives everyone challenges down the road. And so these are things that sort of we deal with on a daily basis for patients without neurogenic bladder. And then when you add on the further challenges of neurogenic bladder and the attendant historical experiences you all have had with your urologist in the past, it can become a very challenging and interesting field. So we'll talk a little bit about what transitional urology is, when it's appropriate to consider transition to a different urologist, how to do that, and then Dr. Messeri is going to talk really about neurogenic bladder with regards to dealing with kidney function into adulthood, as well as management of the bladder and the new challenges of management of a neurogenic bladder in adulthood. So 40 years ago, it was really not expected that many babies born with spina bifida would live into adulthood or live independent lives as adults. And certainly, there's a new paradigm. In 2010, nearly every child that's born with myelomeningocele is expected to live into adulthood and certainly have an independent lifestyle. And so that's really changed the way that the pediatric specialists caring for patients with spina bifida approach patients, in that the goals are to equip, not only to care for the medical issues, but to equip patients with the tools that are needed to be able to care for yourself in adulthood and take responsibility for your personal medical care. And so that's really the objective, I think, of everybody, certainly everybody here and everybody taken care of with patients with neurogenic bladder. But things change in adulthood, as you all know, I'm sure. The bladder changes, and there are other things that happen medically, like diabetes and sometimes problems with the prostate, which can alter bladder function regardless of whether a bladder is normal at birth or neurogenic. And obviously things change as well with adulthood in terms of sexual function. And Dr. Weiner will be talking about this afternoon. I hope you all can participate either in his talk on male sexual function or Dr. Breach's talk on female gynecologic issues. But it really is a transition to sort of figure out how to take patients from pediatric care into sort of this different context of adult urological care. And it's a challenge for the patients as well as for the physicians caring for them. Regardless of who's doing the care providing, urologically speaking, renal failure really is sort of at the top of the list of what we're concerned about. And that's something that can be an increasing challenge as patients with neurogenic bladder become older, because renal function can slowly decline through time. And then the attendant complications of renal insufficiency, including microvascular disease and increased cardiac risk, as well as high blood pressure and those sorts of things, can come into play. And that's something that we really continue to fight throughout the life of someone that has chronic renal insufficiency. But the problem really is, finding urologists that have, specialty training or interest in this, as well as are equipped sort of in their clinics to deal with these problems. Deal with the multiple medical problems, as well as have the social work support and connections to other specialists that they can help, manage all the complex and often competing medical problems. And this is really, in the internal medicine world, the focus is often on dealing with multiple medical problems and sort of balancing them and having a discussion with patients. But in the surgical world, where we all come from, the problem, or sort of the culture, is often, one patient, one problem. You have prostate cancer, I'm going to treat your prostate cancer, and then a couple years later you may have a kidney stone, I'll treat that kidney stone. But there are really very few urologists who feel comfortable or have the time to sit down and say, let's lay out all the problems that are here. Is it leakage of urine? Is it sexual function? What is it? And then trying to prioritize them and address them sort of in turn. And that's really sort of what our objective is. So transitional urology is a subspecialty of urology, which is, albeit in its infancy, that really focuses on patients with congenital anomalies or chronic issues coming into adolescence and adulthood. And of course, patients with myelomeningocele spina bifida are, probably the largest population of these patients. It does require specialty expertise in anatomy and congenital anomalies, and that's really where, pediatric urologists sort of have so much background and expertise. It also requires expertise in reconstructive urology. I'm sure that many of you have had multiple operations, and when you start off with particularly a new surgeon, there's always this sort of question of what's really happened inside there, what's left, how much scar tissue is there. in there, and how challenging is it going to be? What are the sort of risks that are going to be real if we try and make a change to the bladder or fix the stoma and that sort of thing? And that really requires an ongoing dialogue with the patients about what those risks are, because as time goes on and as the treatments sort of accumulate, that does become more of a risk. And as Dr. Masseri will talk about, being hospitalized as you get older becomes, has increased risks associated with it. And I think, the other element of a transitional urologist is to have, to sort of act as a liaison for the patients and an advocate for the patients. To have access to social workers or financial services that might help navigate the complexities of the insurance world or the lack of insurance world as patients graduate out of state-funded shifts. And hopefully the pre-existing condition problem will go away in the coming years, but it certainly has not at this point in time. And I think the other thing is to act as a liaison for other subspecialties within urology. I'm not an infertility specialist, but I have several patients who do have infertility and need testicular biopsy or cryopreservation or something like that. And so for patients in my transitional practice, I actually get them to my partner who does infertility work and sort of are there during the hospital admission for any admissions that need to happen under one of my partners, for surgery that's done by one of my partners, and certainly sort of help communicate and balance all the other medical needs of the patient during their hospital stay or their postoperative recovery. And that's true also with other specialties, because as I'm sure most of you know, this concept of transitional medicine isn't just new in urology, but it's new in really all of the subspecialties of medicine and surgery. And so the initial visit's really the critical visit. I mean, that's really where most of the initial information is gathered, and it can be really tricky to put all that story together, a whole lifetime of experiences with another urologist in whatever, a 20 or 30-minute session. So I really have, I think we all really have a pretty strict protocol for what information we gather and how we gather it. And so when I see a patient with any sort of chronic urological problem or with a congenital anomaly, I sort of get into it right away with bang, 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 all the information that I need. And that can be a little tricky, because sometimes the patients really have different things that they want to talk about, different priorities. And so it's really important for the patients to be able to, specify before they get into the office of a transitional, medicine specialist and say, these are the things that are really important to me. Even if renal preservation's the top thing on your mind right now, these are the things I'd like to talk about too. So I always ask about, the current urological problems and how you manage your bladder, what anticholinergics you're on, what anticholinergics you've tried and haven't worked. The current living situation, both during the daytime, work or school you're in, as well as any goals that you have for the future. Of course, the key players in people's lives, their significant others, their children, care providers, parents, oftentimes, and most importantly, quality of life concerns. Where you've been, where you're heading in terms of what your objectives are for living situation, for partnering, and all these other things that sort of define us as adults. And then, of course, I get into the nitty-gritty of all the prior surgeries and interventions you've had, complications, and make you sign a medical release so that I can get that information from your prior care providers. And then we sort of go through all of these issues: renal function, bladder management, infection history, fecal and urinary continence, stone history, sexuality issues and goals, as well as fertility. Some of those things, again, may be more high on your priority list, and some of them may be sort of weighing in on my mind of things that are really important to address. And I usually try and assess, of all these things we've talked about, what's the thing that brought you here today, and how can we start to work on that problem. And people always say, including my schedulers, well, what age do you start accepting patients? And I think that age is really a poor criteria to determine, when a patient is ready to transition to adult care. And that, I think, really the main criteria should be when the patient, his or her care providers and family members, and the referring pediatric urologist mutually agree that it's time. Either the issues are more adult in nature, or they've become too complex or too different from the sort of comfort zone of the referring urologist. And of course, the most difficult challenge at this point is that there really are very few people who focus on transitional urology. So finding someone who is willing and has the expertise and interest to sort of be that person can be very difficult. And obviously, other life events like moving or changing your insurance or something can often stimulate a change in the medical care venue as well. And so obviously, how to do this is to start with the people that help you in your daily life and are involved in your daily life, your care providers, your partner, your family, as well as your urologist. And certainly, I know Dr. Webb talked about this yesterday. Get a copy of all of your medical records. Maybe not all of them, but certainly all of the operations you've had, any major complications or interventions you've had, important or at least recent radiological testing, kidney ultrasounds or CT scans, urodynamics, so that if those studies are needed in decision making, the wheel doesn't need to be reinvented. And certainly a most recent copy of all of your blood work, including kidney function panel, is an important sort of starting point. And if you can, try and send those records to your new urologist before you get to their clinic, because it can take time to sort through all of that. And sometimes if we have a chance to look through all those records prior to actually seeing you face to face, we'll be able to have a more meaningful dialogue about the things that are important to you. And certainly if you aren't sure, who to go to, ask your pediatric urologist, or consult your local chapter of SBA or other resources, because this is sort of a growing network, and most people certainly can put you in touch with the right person. And sort of what I got back to is really think about these things. Think about what your current urological status is, what your goals are, and try and prioritize them, so that if you get into the clinic and the urologist you're sitting in front of is saying, well, talking about, continence, and continence is really not the number one thing on your mind today, try and steer things back to what you'd really like to address, because there are a lot of competing issues, and they do need to be addressed in turn. And certainly, part of the element of transitioning to adult urology is being, you being in the driver's seat for your medical care. So really make sure that your agenda is heard on that first visit and all subsequent visits. And it's helpful to bring someone who knows your history with you and knows your goals and priorities, because they often bring a different perspective and are able to help sort of articulate some of those things that can get difficult in a situation where time is of the essence. And finally, I always encourage and try and schedule patients who are coming, to me for transitional urology, either at the end of a morning clinic or at the end of the day. and, you know, sometimes that means that your appointment, you know, you don't get to see the doctor till an hour after your appointment slot is made. But the fact of the matter is that's the appointment slot where, you know, we as urologists can really sit down and take a little extra time, and we don't feel like there's a big lineup of people that we need to go in and see. And so you'll get more time and attention to be able to really make sure that everybody's understanding what the objectives are of the visit. If you sort of try and get yourself either in a double slot or at the end of the day, so that everybody feels like they've gotten what they need to out of the visit. So without any further ado, I'd like to turn it over to Dr. Messeri, and we're going to start talking a little bit about sort of the nitty-gritty of the medical aspects that we deal with, and especially with a focus on how things change in adulthood.
Well, good morning. I know that everyone here has a different experience, has seen different pediatric urologists around the country, may have different understanding of anatomy or x-rays or things like that, but I do want to take the opportunity to go through things kind of systematically so that when a doctor might use a word that you don't understand, that maybe you'll have some understanding of what that word means, because we sometimes assume that everyone understands everything that we're talking about, but don't realize that everyone comes from a different background and may not have heard some terms and things like that. I'm going to keep it general. Everyone's experience is different. Everyone has had different surgeries. Everyone manages their bladders differently. So we'll go through things generally, and then at the end we'll have time for some general questions. We really can't focus on maybe your problem in particular because we don't know everything that's in that probably big giant chart that you see when you go to the doctor's office. Real quickly, this is the urinary tract. Here are the kidneys, here are the ureters, and here's the bladder. What happens down here in the bladder really affects essentially what happens up at the kidney. What does neurogenic bladder mean? A neurogenic bladder is essentially a urinary problem where the bladder doesn't empty normally, and this is usually related to a neurological condition, spina bifida being one, could be related to spinal cord injuries and some other diseases, but we're going to focus on spina bifida. The primary goal, like Dr. Wood spoke about, is protecting the kidneys. That is the ultimate, most important thing to us, but of course we're going to care for everything that relates to the kidney and hope to keep those kidneys healthy. So what do the kidneys do? They're essential to life, and if they don't work, we have to replace their function, either with a new kidney from a donor or with dialysis. But the kidneys primarily filter blood, so they take away the wastes that are created in the body, that are floating around in the blood, filter all that out. They maintain acid-base control. This is pretty important. It impacts growth, can affect the development of kidney stones, makes some hormones, helps to regulate blood pressure. So if your kidneys are damaged, you may have some issues with hypertension or high blood pressure. And they help to regulate fluid balance, so they make urine. What can go wrong with the kidneys? You can have infections, hydronephrosis, which is fluid that's trapped up in the kidney. You can have kidney stones or loss of function, and I'll go through each of those. So urinary tract infections. Some people are more prone to have infections than others. And these infections are treated in different ways. In patients that might have several infections, your urologist might decide that you need to be on a prophylactic antibiotic. And what that means is giving a low dose of antibiotics on a regular basis to help prevent infections. Another way to treat infections is to treat them when they come up, when you have symptoms. Now, There are some symptoms that could be very unique to you. Some of my patients come in and say, I feel really tired, and I know that when I have an infection, I feel really tired. Or my urine smells really bad. Or now I'm leaking more than I usually leak. I can't make it the amount of time I usually I usually take to cath. So those things are really important. You know yourself better than any one of us can know you. Your parents or your caregivers know the symptoms. They've helped you along. So if they suggest that maybe this is a urinary tract infection, you might want to keep it in mind. Hydronephrosis. So, that doesn't project very well. But I'm sure you've all had and seen ultrasounds. Usually on an ultrasound, a kidney looks like a little bean. And there's something that looks almost like a white stripe in the center. There shouldn't be anything black. But with hydronephrosis, what you have is you can see that bean shape, but in the center you see this blackness. And what the blackness is fluid or urine that's up in the kidney, and it could be there for several different reasons. You may have always had hydronephrosis and everything is just working perfectly well, but that's just the way you are. Or it might be related to something changing in the bladder. Maybe the pressure in the bladder is too high and that urine can't get drained down. Maybe you're not doing such a good job catheterizing and need to pay more attention, work harder at making sure the bladder's empty. Or maybe there's a blockage somewhere along in that drainage system. Remember when I showed you the kidneys at the beginning and the ureters coming down into the bladder? You can have a blockage anywhere along that. You can have kidney stones. So on the bottom is what kidney stones look like, and they're often small. Here there's one that's 4 millimeters and one that's 5 millimeters, but they can be painful and they can be very dangerous. The best way to look for kidney stones is with a CAT scan, but we like to limit the amount of CAT scans that we do because there's some radiation that's associated with it. So sometimes we'll start out with an ultrasound, and if we see something suspicious on an ultrasound, move on to a CAT scan. On the top here is a CT scan, and you'll see that here's the right kidney, and then in the left kidney there's this bright white dot. It kind of looks like bone, and the reason for that is that it's made up, it has some component of calcium, just the same way your bones have calcium. And then the most devastating thing is loss of renal function. This was the most common reason why children with spina bifida died in the past, and it seems that we're starting to change that trend. It still can occur, and it can be prevented. So it becomes really important to do things that will protect your kidney. So what can you do? You want to drink plenty of water, keep them flushed out. Drinking water will decrease your risk of infection, decrease your risk of stone, keep you hydrated, might improve constipation, bowel problems, make your skin look better. So water's a pretty good, easy thing to do. You want to prevent infection. Make sure that you're doing all the things you've been taught with catheterizing, washing your hands, using a new catheter, using lubricant. You're going to catheterize or void as directed. Remember, taking care of your bladder takes care of your kidneys. Take any medicines that might have been prescribed. See your doctor. If everything's going well, once a year. If you're having issues, you can see them more frequently. And treat those infections when they come up. So our goals as urologists are to prevent problems before they arise, identify which factors we can fix. There are some things that can't be fixed, but we can work hard to fix the things that can be. Identify the risks of any treatments that you've had, and balance the risks and benefits of some treatments. Some treatments might be more risky, might have more risk associated with them than benefit, so you have to think about that. So what does the bladder do? The main purpose of the bladder is to hold urine. It's a big old reservoir, and think of it like a sink. And the way it holds urine is by expanding like a balloon, and also by having an outlet that's closed, kind of like a little faucet or the tie at the end of the balloon. And the bladder outlet becomes very important because if there's an issue with the outlet, either it's too loose or that the bladder is squeezing too hard, you might develop some incontinence. If a bladder stores urine at a pressure that's very, very high, so the bladder is filling and filling and filling, but it's not very stretchy. You know the way some balloons you can blow up and they're really easy to blow up, and some balloons are really hard to blow up. If your bladder is one of those bladders that's hard to fill with urine and the pressure goes up, that pressure can get transmitted somewhere. So either you might leak urine or that pressure will affect the kidneys. You have to have consistent management. You can't typically catheterize whenever you like. You should follow a regimen and a routine. Take anticholinergic medicines. Those are medicines that help your bladder become a more stretchy bladder, like those stretchy balloons. Lots of times you need both. And this is usually the first line of therapy, meaning before we try anything else, we try starting out with these. The risks of the neurogenic bladder, and I keep repeating myself, are renal damage. The other things are the stigma or the embarrassment that might come with incontinence, the complications of incontinence, pressure sores in particular. And our goals are always to maintain those healthy kidneys and then to help with continence. So bladder function can change. It can change as you grow older. It can change because that outlet resistance changes. As men get older, their prostates get larger, so maybe they used to leak before when the bladder got to those really high dangerous pressures, and now because the prostate's larger, you can't leak anymore because it's blocking it off, so that pressure goes up to your kidneys. It can worsen also because of a tethered cord. When I talk about outlet resistance, meaning tightening of that outlet, like when the prostate grows, that's not always a good thing. You might be drier for longer periods of time, but inside it's not a good thing. A tethered cord, and there are lots of sessions on tethered cord, but it's something important to the urologist. A lot of times we work together with the neurosurgeons to see what the significance is of the tethered cord, or if there is a tethered cord. Happens in about a quarter of patients between the ages of 2 and 8. And usually there's a combination of symptoms that occur that kind of turn us on to think, well, maybe this is a tethered cord. You might have some changes in your neurologic system, headaches, might not be able to ambulate as you had before. You might have new issues with urination, more leaking, more infections. Only about 10% of tethered cords, though, show up with a new urologic problem. The urologic symptoms could be new hydronephrosis or fluid up in the kidneys, reflux of urine, incontinence or UTIs, and the treatment is cord release, and the neurosurgeons are those that are involved with that, and they may ask for some studies before doing a cord release, like urodynamics and ultrasounds, and they may ask for those studies afterwards because it gives them an idea of how successful the surgery was at treating the problem. Other causes of incontinence are decrease in that outlet. Again, think about the balloon. If you loosen up the knot on the balloon, then you're more likely to leak. You can have irritation in the bladder. If you have a stone in your bladder and it's kind of moving around and bouncing off the walls, that could lead to incontinence. You can have infection. Or you can have overflow. Your bladder gets so full that that sink eventually will overflow. Same thing with the bladder. As patients get older, the risks of incontinence can go up. Again, the prostate comes around. Vaginal childbirth And weight gain. Weight gain is pretty important. In patients that void normally and patients that catheterize, the more weight you gain, the more likely you are to leak urine. How do we treat incontinence? Well, there's some things that that can be used that are easy to do. If you void, go to the bathroom on a time schedule. If you catheterize, stick to that time schedule. Maybe that schedule needs to be tightened a little. Maybe instead of 4 hours, it's 3.5 hours. Maybe if you're drinking lots of fluids over a certain period of time, you might need to add an extra catheterization in there or limit that time between catheterizations. Pharmacologic agents, which is medications, anticholinergics, ditropan, detrol, oxytrol, all those medications that you may have been on, oxybutynin, all different names of anticholinergics out there. There are some surgeries that can be done that decrease the pressure within the bladder. Botox is something that's used, not very invasive, and we'll talk about it more later. Bladder augmentation. We can increase the outlet resistance by placing a sling, kind of like a little hammock under the urethra, or an artificial sphincter. We can tighten up the bladder neck. Or it can be a combination of all these things that's really what's necessary to become dry. I'm going to go through kind of each of those things and some of the risks. Yes? Sure. The big... the question was, what are bladder irritants in the diet? Citrus, caffeine, colas, carbonation, dyes, artificial dyes in food, and red dye seem to be one of the red dye seems to be one of the biggest culprits. Chocolate, that's not a very popular one to mention to people. And alcohol. And alcohol. The important thing is when you is to eliminate those things, eliminate all of them and then introduce them back slowly. And if something seems to trigger it, then it's a little investigative work. The long-term risks, of course there are risks to anything that we do. Intermittent catheterization has really been the most important thing in helping us treat children and young adults with spina bifida. But there are some risks, and the long-term risks are stricture in up to about 20% of patients. Trauma from catheterizations, can't get the catheter in quite right. Epididymitis, these are all related. Epididymitis might be related to infection. Remember, this is a clean technique and not a sterile technique, so there is a slightly increased risk of infection. Access. How do you get to catheterizing when you're young and thin and small? It might be easier to find the urethra than when you get older and may have gained some weight. Your mobility may have changed. How do you get supplies? Do you need different catheters? Do you go up in sizes? Who's going to be your supplier? Does your insurance work with that supplier or that supplier? And trying to keep that all straight is sometimes very difficult. The anticholinergics have some side effects. Dry mouth and constipation, headaches. Some people have issues with concentration. Some people have issues with not being able to sweat. And then there's the cost that's associated with them. Oxybutynin is one of the only ones that has a generic form, and that might decrease on cost. How often do you take it? Can you remember to take a medication 3 times a day or once a day? Can we get your insurance company to pay for a medicine that is only taken once a day? Can we limit the sleepiness that's associated with it? Are there any drug interactions? It's very important for us to know what medications you're taking. So if your primary care doctor recommends something, please let us know, because we might recommend something else and they interact with each other. And then how do we give the medicine? Do we give it by mouth? Do we give you a patch? Do we put it in the bladder, which is a much less common mechanism of giving the medication? And then we'll move on to surgery. Now, when I say surgery, that means going to the operating room. It doesn't necessarily mean having a big old incision or anything like that. And what are our goals in surgery? We can make the bladder larger. Okay, so having a big bladder doesn't really matter, but the most important thing is having that pressure lower so that the kidneys don't see that pressure. And there's bladder augmentation and Botox, and there are some experimental therapies. Many of you may have heard about the Zhao procedure that was described by a doctor in China, whereby they reroute some nerves, and this is still considered experimental, and we're still waiting for data from the United States really before we start recommending it. In other sessions you may have heard some about it, but that's still considered very experimental, and there are only limited patients that are candidates for it in the United States. Other operations we have can make the outlet tighter. Remember, again, go back to the balloon. We want a stretchy balloon with an outlet that's tight. We can make it tighter with a sling, and I'll show you a picture of that, but essentially I think of it like a hammock that keeps things up, an artificial sphincter, or a bladder neck reconstruction. And how do we decide what's best for you? Urodynamics, I'm sure, are familiar to most of you. And what urodynamics do is they give us an idea of what's going on in the bladder. What's the pressure within the bladder? And we know there's a magic number that's 40 millimeters of mercury. So when they looked at patients, and this was after a spinal cord injury, they noticed that if the pressure in their bladder got above this number of 40, that this was dangerous to the kidney. It tells us about the capacity of the bladder. If the bladder capacity, or the amount of urine that's held in the bladder, is small, you might have to catheterize more frequently or use the restroom more frequently. And then outlet resistance. That tells us whether you need to have a sling or a sphincter or a bladder neck repair. If that outlet is fixed in one position, then no matter how big your bladder is, it can always drip out. Botox has also been described for use in the bladder. It's great. No incisions. We look in the bladder with a telescope and we inject Botox. Same thing that people get injected for their wrinkles so that they don't have wrinkles anymore. And what it does, or for contractures and spasticity in legs, what it does is it relaxes the smooth muscle in the bladder, so it makes that balloon more stretchy. The problem with that is that it has to be repeated almost every 6 months. The side effects are rare and minor, and it does help lots of people. The main issue currently is the need for repeated procedures, and also the insurance coverage of these procedures and the cost that's associated with it. So we'll see how that goes in the future. We'll talk a little bit about bladder augmentation, and just kind of, some of you may have had your bladders augmented, just to give you an idea of what happened and how things are different in your bladder now. So essentially your bladder started out like that circular thing that I showed in the previous slides. And when you have a bladder augment, a piece of intestine, or now rarely a piece of stomach, is used, and a patch is created and it's placed on the bladder in order to make that bladder larger. That piece of intestine that's taken away from your intestines still has blood supply with that, and that intestine is reconnected. So there's not any free-floating intestines. It's just a little bit shorter, and the ends are put together. And that piece of bladder is then placed, that piece of intestine is placed on the bladder to make it bigger, to make it stretchier. Other things that are done surgically are catheterizable channels. Your doctor might refer to it as a Mitrofanov or a Monty or a Monty-Yang or an appendicovesicostomy. Essentially all these terms are variations of a tube that allows you to catheterize not through your urethra or the natural tube that goes to the bladder, but a tube that opens up onto the belly wall, either at the belly button or somewhere else. And that may decrease the risk of strictures in your urethra. There are some risks associated with it, primarily that the opening at the skin can narrow down. That can happen in up to 20% of cases. The real benefit here is that you can just pull your pants down and catheterize without having the issues that are related to access to the urethra. Some studies that have been done, and they compared patients that had the ability to continue to catheterize per urethra or catheterize through their channel. Most people preferred to use their channel because it was much more convenient. We'll talk about the slings. So this is kind of a fancy picture here. Here's the bladder. Here's the urethra, okay, or the outlet. And then there's this material that comes around the urethra and pulls things up. And by pulling things up, it increases the pressure that's at the outlet. These can typically in children are done through an abdominal incision. In older girls, they can be done transvaginally. It typically cannot be done in a young girl because the vagina isn't large enough to allow for the passage of the sling material. Another thing that's available is an artificial urinary sphincter. The people that are good candidates for sphincters, there are very few people that are good candidates for sphincters. And those are primarily people whose bladders work pretty well, but the outlet is pretty loose. So what you want to do is you want to increase that outlet. You also need to be able to void or to urinate by yourself without catheterizing, because if you pass a catheter through this sphincter time and time again, what can happen is that this sphincter, which is made out of plastic, can erode. And that can require the sphincter to be taken out, can cause infection, and can cause stricture in the urethra. The outlet procedures, though they work very nicely and can help one become continent, can change the storage pressures in the bladder, so the pressure gets higher, the kidneys see it, and they respond in a poor way. Urodynamics are done afterwards to make sure that none of that stuff is going on, or to identify that before it becomes damaging. So just some general things with surgery. The risks of surgery increase with increasing age, and they increase with increasing weight. So your risk of having infections or having a heart attack after surgery, or pulmonary problems after surgery, or clots in your legs, or deep venous thrombosis goes up as you get older and as you gain weight. After surgery, there are long periods of immobility, so you may not be up in your chair, you may not be walking. It becomes hard to position as you get older. Sometimes scoliosis gets worse. Contractures in your legs may become worse. It could be hard sometimes just to get to the abdomen. In patients with scoliosis, in patients with contractures, there's a potential for fracture As you get older and you're exposed to latex, maybe not intentionally, your risk of allergy goes up. You can't breathe as well. Your lungs don't expand as well as they used to. What are the long-term concerns associated with some of these therapies? And now talking to adults, these become very important. As children, we kind of think, yes, that might happen, but in adults, you start to see these things happen. So with catheterization, it's stricture, positioning, access. With bladder augmentation, again, catheterization is very, very important. If it becomes difficult to catheterize, you might jeopardize your bladder augmentation, have a perforation, which could be a very, very dangerous and life-threatening complication. Continence again comes up, and tumors within the bladder. So some patients have been found to have tumors within the bladder, and we'll talk about that. Other things, stones within the bladder, vitamin B12 deficiency, rupture of the bladder, or malignancy or cancer. Some of these things are preventable. Oral vitamin B12 seems to do just fine at taking care of vitamin B12 deficiencies, adhering to irrigation schedules, catheterizing on time. Those cut down on your risk of stones. Decreasing the number of infections cuts down on the number of stones. Rupture, catheterizing, making sure that you're catheterizing and not foregoing it. That decreases the risk. Malignancy, you can decrease the risk by not starting to smoke, okay? Smoking increases anybody's risk of bladder cancer, and if you have a slightly increased risk than the general population and then you smoke on top of that, that makes it even worse. You want to make sure that you're treating urinary tract infections, you're treating stones. Stones cause inflammation. Kind of think of them bouncing up and against the walls of the bladder and really always constantly damaging the bladder. Indwelling catheters. So our goal really is to keep catheters out of the bladder as often as we can. We know from other groups of patients, patients with spinal cord injuries, patients before intermittent catheterization was introduced in the 70s, that they had an increased risk of bladder tumors. And augmentation cystoplasty. Now, you may have heard that this increases your risk of cancer, but the jury's is still out. We don't know if it's related to the augmentation or the chronic infections or intermittent catheterization, or is there something that's innately wrong with the bladder, with those cells of the bladder that didn't form normally. So we really don't know the answer to that. We know that there is this risk, and we know that there are some things to look out for. You should see your doctor if you have blood in your urine. Now, you may have some blood because it was really hard to get the catheter in that day, or your channels get narrow, or the eye of the catheter, as it was coming out of the channel, irritated things. But if you're seeing blood over and over again over the course of a few days, call your doctor. We'll try to help troubleshoot what's going on and make sure that we're not, and you're not ignoring something that's very important. If you suddenly have more urinary tract infections, more than 4 a year, and this is different for you, you need to let us know. If you're having troubles catheterizing, you just can't get the catheter in anymore. We need to know that. Some of your doctors may be doing surveillance cystoscopy, whereby they look inside the bladder maybe once a year, maybe every other year. And again, there's no general consensus as to when you should do it. And they're looking for stones, looking for the health of the bladder, looking for tumors. Cytology is where urine's sent to look for any abnormal cells. And if anything looks abnormal, a biopsy might be taken. And of course, lifelong urologic follow-up is needed. So if your pediatric urologist says to you, I'm sorry, you're 18 or you're 21, I can't see you anymore, ask them, who can I see? Is there someone you know that's interested in seeing me, or someone that you trust with my care? Some people will have some good ideas about people that they may have trained that understand this surgery. That might be very helpful for you. So remember, always the best thing is to ask. You can ask your friends if they know anybody. And then always understand that if an adult urologist says, I can't care for you, it probably means that they're uncomfortable with your history, and they might not understand everything that you've been through over your life. So I ask them, do you know anyone that can help me? And then, of course, you can always ask one of us that's here. You can ask the helpful folks at the Spina Bifida Association. So in summary, bladder function changes with age. We need to keep an eye on it forever. The goals and the priorities of a patient may change. Though we have in our minds what's very important to us, you have to tell us if there are things we're not hitting upon that are important to you. There are things that we may have done in the past, surgically or medications, may have new risks as you get older. And again, remember, find a urologist who's going to be with you for the long haul. It may not always be your pediatric urologist, but once you find someone that you trust and that understands your problem, make sure you stick with them. We're going to take some questions, but and this is a long session, if you want to take a little break, maybe a 15-minute break, and come back and we'll answer your questions, get to the restroom and all.
Let's reconvene around 20 minutes to 11.
My son had his the channel done for the catheter in Riley, and then have the surgery.
Questions? We can wrap this up a little bit early. Any questions?
We just had one question about bladder irrigations during the break. If your bladder is augmented, it does make lots of mucus because intestines make mucus, and even though that intestine isn't continuous with your intestine now and it's part of the bladder, it still makes mucus. So you still have to irrigate. That's really, really important. Cuts down on infections and stones. So if you've been instructed to irrigate. It's really going to help you out in the long run.
I have another question, but I guess to that, how do you irrigate?
I think everybody has a little bit different style of how they instruct patients to irrigate, and I know there was a question yesterday in the session with Dr. Webb, how much fluid do you irrigate? And his response was a very good one, which is irrigate until you don't get any more mucus. So for some people that may be one syringe fill, and for other people it may take 20 minutes of pushing stuff in and out. Some urologists are very specific about, you know, what kind of solutions to irrigate with and this sort of thing. I actually tell my patients to go to Costco or wherever, Sam's Club, and get a flat of water and just use a fresh bottle of water to irrigate out, particularly if insurance does not cover saline, as long as you drain that water out after you irrigate. To be honest with you, I don't have, and Dr. Masseri may feel very differently about this, but just to get the sediment out is really the objective. So I don't know if you have a different...
It really is to get it clear. So usually a 60 cc syringe. Put it in slowly. Some people are more sensitive as you're injecting the solution than others. And then withdraw. If it comes back clear, I would still do another 60, withdraw if it comes back. If you continue to get mucus, just keep doing it until it's clear. Because what happens is the mucus will settle down at the bottom of the bladder, so what you need to do is make sure you're getting that. So if you have a channel, sometimes it's a little harder to drain out that mucus than if you're coming in from below. I use normal saline to do it. I have 4 other partners. We each have our own little biases. I think the most important thing, though, is to get it clear. And for some kids, it's 60 cc's every day. For some kids, it's 180 cc's. One of the biggest problems is really, I think, to get people to irrigate. Because sometimes I'll ask, when was the last time you irrigated? And the answer is, not since last time you told me to do that, which was a year ago. But it really does help cut down on stone formation, infection. And everyone makes a different amount of mucus. Some people have very little, some people have lots and lots.
My second question was with respect to the Botox injections. Recently, a urologist told me about a new filler. I think it's microplastique might be the name. I don't know if you've heard of it or any experience you've had with it, and if it's potentially more effective and more long-lasting than Botox.
Was that for leakage of urine?
Yeah, for like the sphincter.
They work differently. What Botox will do is it'll relax things. What the bulking agent will do is it tightens things. Most of the experience that I have is with deflux, and really have some variable results. I haven't used macroplastique, so I can't really talk about my successes with microplastique. Of the patients that when I was a fellow, actually looked back at all the patients that had had deflux at their bladder neck in order to help with continence. 100% of the patients said they would repeat it again, and that was primarily related to the ease of the procedure, not necessarily the success. So I have some mixed success with that, and it works very well in a certain population of people. Do you have any macroplastic? Any other questions? Use the microphone.
Since the pediatrics hospitals made the adults leave, and there are different hospitals in our area are trying to get an adult clinic together, but right now they still don't have a urologist. So the last time the full studies for the kidneys were done was in childhood, but now as an adult has an auto augmentation and an artificial sphincter, but they didn't test the pressure. And I remember when he was little, they tested the pressure, on the kidneys, but they did the renal sonogram and the ultrasound. Does that tell them that the pressure's okay and you don't need to do the pressure study?
We kind of talk about this together because there are 2 schools in urology. One is kind of the proactive school where every year you'll you do your dynamics, check to see how the bladder is doing, regardless of how the kidneys look. And then there's another school that says, well, if the kidneys look good on the ultrasound and they're not having any difficulties with leakage or infection or anything like that, then maybe we don't need to repeat those studies.
Would you suggest going back to the pediatric urologist who put the artificial sphincter in and did the auto augmentation?
For urodynamics?
Yeah. Because I noticed there's a huge difference in insurance and what they used to do automatically. Now the doctors are sort of like fighting, well, you don't really need that, and go ask your primary care instead. It seems like it's really, there's a big difference on what they're afraid of the insurance.
I have to say that I'm more afraid of what insurance doesn't pay and you might be stuck with than insurance itself. But I strongly believe that if a test is necessary and warranted, that and that we're dealing with important things like continence and kidneys, that the test be ordered. And I don't know how your pediatric urologist feels about doing urodynamics on an adult. There are some pediatric urologists that feel very strongly that you're 18, you're graduated, and there's some pediatric urologists like myself who say, well, I'm going to take this on a case-by-case basis, or this is something that I like to do.
I think in particular, if you've had an outlet procedure and a procedure to reduce pressures in the bladder, that sort of suggests, again, it's hard to know without knowing all the historical data, but it sort of suggests that there probably is at least a rationale to periodically look at what the bladder pressures are doing. Particularly if there are problems with increasing leakage or other problems associated with the bladder function, irrespective of what the renal ultrasound looks like. And so, I mean, I think if you have a concern about it in your mind, it's probably a justified concern, and you can go back to the pediatric urologist, or you can see another urologist in your region that might be able to just shed a little bit more light on. So
if it's been years, you would have that done?
Again, it's hard to say, and we don't want to get into the details, but I think that if it's a concern that you have, it's probably a warranted concern that to at least have a discussion with someone about that and have someone look at all of the historical information.
And I just have one other question. In your talk, doctor, you had said that you can't have an artificial sphincter and cath.
Well, that picture actually was a picture of the sphincter around the urethra. And sometimes with patients with neurogenic bladder, we actually put the sphincter around the bladder neck, which changes things a little bit. There are sort of different scenarios, but normally we don't put an artificial sphincter on the urethra if someone is cathing, unless they deactivate the sphincter every time they cath.
Thank you.
All right, I have a question about bladder infections. I've had a chronic bladder infection for maybe 3 or 4 months, and it keeps reoccurring. And I was living in a dorm at the time, and so it was a public bathroom. I would use it 2 or 3 times a day, every day for the whole week. And then I just came home about a month ago, and so I'm using my home bathroom all the time. And so when I came home, the infection just cleared up right away. And so I'm wondering, do you think it could be a possibility that the bathrooms were part of a factor of my bladder infection? Since it was a public bathroom, and I don't really think they were cleaned all that well, I don't have the proof, but that was just my gut instinct.
Well, that's a really hard question, because there's so many variables. How well can you wash your hands? How long are you taking to cath? Did the catheter touch anything?
I mean, I I had done everything that I usually do. I've done as many hours as I'm usually doing. I've done everything I've ever done. Just the only difference was I was in a different setting. But then I was also starting college because I just finished my first year of college. So I wonder if stress could be a part of it. I mean, my gut instinct is it was the bathroom, but
or the infection just ran its course.
Yeah, I mean, I just got rid of it, and I've had it for maybe a couple months, and I couldn't get rid of it.
There are other things that impact infection too, like the pH of your urine or the acid-base balance of your urine. So if you were, on a different diet, taking different types of fluids, all those things can sort of change the ability of an infection to set up shop or clear. So, a different environment, just by nature of it being changing the urine, can also change infection risk.
Okay.
Somebody else. There we go.
You briefly mentioned the experimental treatment. Could you elaborate more on them, especially the nerve bypass?
Dr. Weiner, who's one of our pediatric urology colleagues, is going to talk about that at the Ask the Doctor session after lunch, and he has a very nice presentation on that to give you more detail.
Is there anything other than the nerve rerouting?
More than nerve rerouting, that's, there are always people working on artificial bladder replacements and scaffolds and things like that. But nothing that's, there was one trial, and do you know if that's still going on?
And these are like stem cell type of therapies.
Yeah. Is the stem cell now going on? And is
Nothing
it good?
that's ready for prime time.
Sorry?
Nothing that's being done in patients currently, in human beings.
I understand there was a study about somebody done a bladder from the stems, a new bladder.
There's a limited number of patients that were in that study, and that's closed.
Closed.
The results probably aren't as good as we would have liked for them to have been.
Having done these sessions for a while, I'm John Weiner in Durham, North Carolina. I'm a pediatric urologist, but we don't have a children's hospital, so I take care of all ages. A misconception with that tissue engineering is that people think that they're making a bladder that is going to work differently than your bladder. All it is a way of augmenting your bladder with tissue from your own bladder rather than from your bowel. But it's not going to really change the way your bladder works any different than augmenting it with a piece of bowel. So I think there's a misconception when they talk about tissue engineering that they can put in a bladder that's going to fill and empty and like a normal bladder, and it's not. It's just a way of making the bladder bigger. So I think people get a lot of patients in my area were all excited that they weren't going to have to catheterize anymore or something if they had this done, and it doesn't change that at all.
I have a urostomy. Do you guys have any experience in that?
Yes.
Okay. Is there a way? I usually have a hard time fitting my ostomies on. Depends on, sometimes the stomach will swell up, and it feels like I've got pain in my back sometimes. And if it swells up and the hole is too small for what I've done, and I haven't gotten as many infections as I used to, but it's kind of a pain. And they were thinking about taking one of my kidneys out. And they said that I got nephritis in one of them, that it's so small, it looks like it stopped functioning.
Well, that's a very specific question, so it's really hard to answer, not being your urologist.
Oh, sorry.
I had patients who had Metrophona procedures in the past, and afterwards they have leakage from the stoma as a part of the post-surgical complications per se. And I was just wondering, what's the rate of complication with that procedure, and any recommendations for incontinence after the surgery has been done?
It depends who you ask. I think the way I think of any continent catheterizable channel, a Metrophona or a Monty or whatever, is that really if the patient lives long enough after that surgery, they're going to have a problem with it. Okay? Either stenosis at the skin level, which is usually just a quick fix in the operating room, or leakage, which requires revision or injection of a bulking agent, sort of to act as like a sphincter mechanism. So the published rates, I think, grossly underestimate, because a lot of them just look, a couple of years out after surgery. But if you look long enough out after surgery, if someone is catheterizing a channel, it's going to have a problem. And so I approach any catheterizable channel as something that just needs to be managed just the way you need to, and checked up and fixed the same way you need to fix up and check your car if you're using it every day to do what you need to do. And so leakage is one thing, blockage is the other thing, and those are that's sort of the battle, because it's not a natural, it's not something that was sort of created for that purpose. It was created by by human hands to function.
The other thing that's really important is to make sure that when that leakage occurs, is it continuous? Is it when the bladder gets to a certain capacity? Because sometimes if the bladder is over distended, it may begin to leak out the stoma.
Yes, I had a question. What type of issues do you see in transitioning to adulthood with an individual who has an artificial sphincter with the bladder pump?
For me, what I've noticed is that most of those sphincters are no longer functional that were placed in childhood. And though they're not functional, they continue to be active in preventing incontinence. But the thing that's most worrisome to me is erosion, more than malfunction, where you just can't cycle the sphincter any longer. It's erosion, and I keep a pretty close eye on the young men that I see with sphincters, even though they no longer function, just to ensure that they're not eroding.
And there really aren't any data. Oh, sorry, go ahead.
No, I'm saying what would be some of the symptoms of an erosion of the sphincter? Just problems with
You can have redness around the skin, in the scrotum, the penis, anywhere along the tubing. So usually that's over the pubic bone, usually off to the right side is my preference.
The pump can become fixed and difficult to manipulate or painful. And recurrent UTIs is another thing. If the device is eroded into the urinary tract, even if you sort of can't appreciate that there's any swelling or anything around the pump or the tubing, it's a foreign object. So you will continue to get serial urinary tract infections in that setting.
particularly if they catheterize themselves? Thanks.
I have a quick follow-up question about the Botox and other things that you can use. What was the macroplastique? My urologist is actually recommending collagen. Would that kind of be the same thing in terms of a bulking agent? Mm-hmm. Do you see any reason why not to do something like that?
Collagen you can have an allergic reaction to, so you have to be skin tested for it. But it's actually my bulking agent of preference because it's a biological material, so it's absorbed and that sort of thing. So the sort of fear of having a foreign object in there that could become a nidus for infection or chronic inflammation is not as strong. So that's really the main risk with collagen, is the allergic aspect of it.
Because it's a synthetic or it's not synthetic?
It's actually usually manufactured from cows, so it's actually biological as opposed to synthetic.
And my second question, just quickly about the artificial sphincter. I know my urologist was saying the same thing, problems with erosion and such like that. So is there a more modern version of a sphincter? Like, is that something that you would do now to a patient?
I do I put in a lot of sphincters for other reasons. Not for women, though. I don't think that they're great for women, actually. We can put them in for women, but I just don't think that they work very well, just because of the anatomy is different. So, and I think actually slings work better for women. So it's a lot of personal preference. Anytime you do anything to a patient, and that sort of hits home with what Dr. Masteri and I were talking about, is that there's always a risk. And so really deciding how to proceed should be a balance of what the risks are. And I always tell patients worst case scenario versus what they would be potentially gaining from the intervention. So if it's worth it enough to you, and that's the great thing actually about taking care of adults, I think, is that that decision is in your hands. You're totally capable of sort of appreciating what those things are and playing through all the scenarios in your head. And if that's how you want to proceed, then that's what I'm willing to do, and I know what Dr. Masteri is willing to do, or Dr. Weiner. So lower risk procedures, we have sort of a lower threshold for just doing, even if they might not work super well, like injection of bulking agents, versus higher risk procedures like making a big cut from stent to sturm and putting you in the hospital for a couple weeks to do a big bladder reconstruction. So that's part of the dialogue that you should have with your urologist.
Yes, I have a ileal conduit and have problems with getting the bags to stick. For just in general, what would you suggest to get those ostomy bags to kind of stay in place?
I think that the best thing that you can do is call your local hospital and see if there's an enterostomal therapist there, because at least at my institution where I work, they are super at troubleshooting things. They know all the, they know all the products that are available out there. So if maybe you've tried that already and haven't had luck, maybe try.
We haven't.
Yeah, and I would start out there because they really do some magic.
Okay, thank you.
And to be honest with you, oftentimes it's the stoma nurses that say, this patient's been through it all, and now it needs surgical revision. So, because they're the ones that really know when all the options for appliances have sort of been depleted.
I have a two-part question on the bladder irrigations. For several years after an augmentation, the bladder irrigations went great. They'd come back clean. And then there was an episode that obviously changed the dynamics, and it took several months to clear up an infection. But since the infection, we don't seem to be able to get, he still gets clean irrigation after saline irrigations, but there is constantly mucus in the urine. If there are no symptoms of urinary tract infection, is the mucus in the urine problematic?
I think so long as you're trying, it sounds like you're taking steps so that it doesn't accumulate in there. I think you may see some little strains of mucus in there.
And then the other thing is they said, well, because for 3 years he did not have that, they're still attempting to get it normal. Although I'm thinking this may be the new normal. Do they ever do like mucolytics, like acetylcysteine or anything like that in an irrigation, or you prefer just to stick with saline and things like that?
I tend to stick with saline because the results with the mucolytics are really kind of not consistent. I mean, the literature that's out on the mucolytics is kind of all over the place as to how successful or unsuccessful they are. So unless he's having issue with recurrent infections or bladder stones, I probably would stick with the normal saline.
Any other questions? Everybody over here to go, and then everybody over here.
Besides taking like ditropan or antibiotics, what about like taking cranberry pills or anything to help with your bladder, fighting infection?
I mean, that sort of gets to this issue of changing the actual chemistry of the urine to make the urine less prone to getting infected. And so there are some dietary things, and a lot of that is trial and error, sort of like what Dr. Messeri was talking about with just dietary intake of various caffeinated products or alcohol or citrus, whatever. So if you're sort of systematic and scientific about adding things or changing things in your diet and then assessing what your urinary tract infection risk is, you just have to find what balance works for you. I've had really good success actually with some patients. Some patients don't respond to it at all, but some patients respond really well to a probiotic added to their diet as well, for whatever reason, that have problems with recurrent urinary tract infections.
Do you recommend ditropan for ostomates or not? Because I have a problem. My bag will not have anything. My bag will not have anything in it. And then if I'm in a vehicle, because it shakes, it seems to start in my ostomy again.
It sounds like your ostomy needs to be looked at. I would think that that's probably, if you say that when you're in a situation where things change, it sounds like your ostomy may need to be looked at by either the surgeon that did it or the urologist that's caring for you now.
Okay, thank you.
And typically the ditropan type drugs are only useful in the setting if there is native bladder that's being used as part of the urinary reservoir.
Just going back to bladder irritants, like before I tried something severe as giving up coffee, like how much time would you need like for trial and error before you can really tell if it's something that is significant that could affect it?
I generally say 2 weeks.
How often do you get urinary infections?
It varies, but I mean, I've probably gone months, but then there are times that it's like every month. Yeah. So I think it's a combination of like stress, and I don't know if there's other things that could contribute to it like that. I mean, I've recently, by going to these sessions, heard that that's something, and I didn't realize it was such a factor.
The other thing, too, that seems to affect women is around their menstrual cycle. Things seem to change a lot. Continence, risk of infection seem to be affected by that as well. So kind of look to see if there are any associations, jot things down, how you're feeling in a little calendar. That seems to work well for some people because then they start to see trends.
And how about using prophylactic like antibiotics like macrobid or something like that? Is that generally recommended? I've had doctors saying, let's not do it, let's, trial and error on that, but...
If you can identify a specific trigger for your infections, for example, intercourse with a new partner, or at the time of your menstrual cycle, for some patients it may be warranted to take medication just around those periods of time to prevent the infection from occurring. That's a pretty rare scenario, but there are patients for which I recommend prophylactic antibiotics during those time periods, or at that time period.
But not like for a long period of time, like staying on it, so this way you never have to really kind of monitor the timing?
It really depends on the frequency and the severity and other things that might be associated. So it's a very very, very specific case-by-case thing. There's a little philosophy, each of us has a little bit of a different philosophy. Do you give a prophylactic antibiotic and then you lose that from your medicine cabinet because you become resistant, or do you treat them as they're coming up? And different people have very different and strong opinions about that. But I usually go by really on a case-by-case basis.
And I usually actually recommend self-start therapy for, I think I have one patient that I put on prophylactic antibiotics, actually, and everybody else I give a urine culture bottle and a label and a prescription, which I tell them to fill and always have in their medicine cabinet. And if you get that symptom starting, at 10 o'clock at night on a Saturday night, take the urine sample and start taking the medication right after the urine sample, and drop the urine sample off with us so we can get a culture on it, so that there isn't this issue of feeding resistance. But you're not inconvenienced by having to spend Saturday night in the emergency room for a urine culture.
Right. Which is funny because I think some doctors, like I've heard, we won't prescribe anything until you give a culture, and that will wind up happening because they're, I think I've heard that a lot of times people who do get recurring UTIs kind of like self-medicate, so that they'll keep extra pills or whatever, so this way when they first start getting symptoms, before they get really bad and they become flank pain and all that, that they'll, start treating. And but then again, I also think like having to spend like hours, in the hospital just for, getting a urine culture too is like common. So
yeah, and really trying to get that urine culture before you start the therapy, even if you're starting, is so helpful, because then we can go back and say, well, we're treating the same bacteria all the time, or this is a different bacteria with different resistance and things like that. So the urine culture is important, and you come up with a plan with your doctor that works best for you. Some people live close to where I work, some people live really far, so I'll send them to their primary care doctor's office for it.
My doctor usually tries to start me on something that's worked before so that he doesn't have to, because mine usually turn out really bad if he waits. So I do really well with that kind of therapy.
I think let's have this be the last question, and then if you have any other questions, you can catch one of us.
I stepped out, so I hope somebody didn't ask this. How often do you recommend the Urodynamics done to test the pressure?
That's a very hard question, and if you find the answer to it, can you let me know? Because it really depends on what interventions you've had, what history you have, what your symptoms are, and even a bunch of experts that do this probably don't agree totally on it. I know Dr. Masseri and I have had conversations about that just in the past day or so about when is it important. And certainly we know that it's different for adults than for kids, because these issues of growing and changing are different, and adults are more able to articulate when their symptoms are changing and that sort of thing.
So you wouldn't have a recommendation for 13-year-olds how often we should do it?
For different disease processes, I think that it's probably important to see what's happening around the time of puberty, because there's lots of changes going on all over the body, and I think it probably is important to, if you're not doing them on a yearly basis, which is the recommendation of some urologists. I'm not telling you what my preference is, but getting them at key times when things are changing. If there's any sort of change, they need to be done. But then again, looking again around puberty, because there's such an enormous change going on in the bladder, and seeing that nothing there is being affected. Tethers become more common during times of rapid growth. So I would probably say if they haven't been done in years, that around puberty is probably not a bad time to look. They're very different philosophies, and different people have different feelings.
I think most people would agree, though, that at the time of puberty is really a critical time to be watching pretty closely.
Okay. You were talking about if you had an artificial sphincter, it's not recommended to cath a lot through it. What about if you have a Metrophenolf and you don't have the sphincter, but you want to get him dry? Would you recommend the sphincter or a sling?
I would probably go with the sling.
Wait, he's leaking from his urethra?
Yes.
And has a Metrophenolf?
Yes.
And he's not cathing through the urethra ever?
Except maybe to flush every so often.
I have to say there's a couple of different, for males, there's a couple of different sling products on the market. And one which I never use for any type of patient except for spina bifida patients. And so it's a sling. I mean, I don't use it for post-prostatectomy incontinence or anything like that because I don't think it works very well, but I've had a fair amount of success, as have a couple of other urologists using that type of sling. That's one that actually anchors into the bones of the pubis. And so there may be, and that's a sort of outpatient type of procedure, maybe stay overnight sort of thing. So sometimes you can get a patient a little bit, if they're just having a little bit of leakage, particularly at the end of the cathing interval, sometimes that is useful to sort of get things totally dry. The durability of those treatments is not well defined, but certainly the risk of doing a sling is a little bit less than putting in a prosthetic like an artificial sphincter in terms of infection and that sort of thing.
Thank you.
Okay, I think that was the last question, correct? And when you leave, if you wouldn't mind leaving your evaluation, and also if you use the little pen with the cute little happy face ball on top, if we could have that back. That would be great. Thank you.
Thank you for attending this session. Because meeting your needs is important to us, we need your feedback on the presentation. Please take a few moments to complete our evaluation, which can be located by clicking on the presenter's name located to your left on the screen. It will only take a few clicks of your mouse to provide us information to make the SBU experience better for you and others. If you have any questions relating to SBU, please contact us at sbu@sbaa.org. This presentation is brought to you through an unrestricted educational grant from Hollister Incorporated.